थोडा टाइम चेंज करायचं का याचा जरा इव्हिनिंगला आयदर लेट इव्हिनिंग 7 ते 8 वगैरे.
अरे ते तर गडबडीचं असतं ना, उलट आता मध्ये ब्रेक घेऊन परत तुम्ही फ्रेश उकडी संपवू शकता ना. टी ब्रेक सारखं चहा पीत पीत हे उरकून टाकायचं. मग आपण मे बी 30 minutes डिस्कशन मध्ये जातो.
So good evening everybody. I am Rahul Chobe from Rheumat TV and also Ortho TV because today's topic is for both orthopedician also and rheumatologist also. So I'm handing over this session to Dr. Nilesh Patil. He will introduce the speaker and the panelist.
Thank you, Rahul Chobe sir. A very good evening to everyone present today. I would like to thank and congratulate Sancheti Hospital and Parag sir for this wonderful concept of Rheumat TV. I am Dr. Nilesh Patil, rheumatologist working with Sancheti Hospital for the last 4 years. Today, we shall be discussing about rheumatoid hand and its sequelae. So, I would like to welcome Dr. Altaf Warid, who is today's keynote speaker. He is a hand and upper limb surgeon, and he has done his DNB in ortho with a gold medal. And after doing his DNB, he has done fellowship in hand and reconstructive surgery. So he's expert in trauma, microvascular surgeries, and nerve surgeries, peripheral nerve surgeries. So I have been closely working with him for last 4 years. I'm really happy that such a wonderful, skillful surgeon is working with us. And then we have with us today a team of eminent rheumatologists on panel. Dr. Ajit Nalavde, a senior rheumatologist, and he's heading the department at Sancheti Hospital. He's been involved in many clinical trials, and he has done his DNB from KEM, then fellowship, and he has also done his ULOR fellowship. And he's always helping us and guiding us for so many things. Then there is Dr. Gayatri Ekbote, who has done her DNB in rheumatology from Medanta Institute, and she has worked on extensively worked on vasculitis there, and now she's been attached with Sancheti and as well as Sassoon Hospital. And then we have Dr. Abhishek Zawad, who is astute clinician and who has done his DM from HGPGI Lucknow, and now he's been attached with Ruby Hall Clinic. So the today's topic is rheumatoid hand and its sequelae. So in our day-to-day practice, we see so many patients who come with the leg disease. So there, the patient always asks, doctor, what to do now? So that is all the discussion all about. Yes. So I would like to start. Yes. Dr. Warid, over to you.
Yeah. Good evening, everybody, and thank you so much, Dr. Nilesh Patil, for that kind introduction. And I'm very thankful to Dr. Ajit Nalavde, sir, Dr. Gayatri, and Dr. Abhishek, who have joined as panelists. So I think without wasting any time, we'll just go on with the presentation first, and then we'll have some discussion at the end of it. So is this visible? I think it's okay.
Yes, it's visible.
So the topic for today is rheumatoid hand and its sequelae. Basically, I would like to start my presentation by saying that hand surgeons are an integral part of the management team for patients with rheumatoid arthritis. That is definitely there, but at the same time, from a hand surgeon perspective, referral to a hand surgeon does not equate to failure of medical management. So it's basically a medical disease. Rheumatoid arthritis, it's a systemic inflammation which involves the various organs in our body and of course the musculoskeletal system. And basically it has a medical treatment. And then the sequelae, if it is remains untreated, then it needs maybe some particular orthopedic intervention. So hand surgeons today have less exposure, in fact, to treating rheumatoid hand. But despite more effective medical options, surgery may still offer may still offer patients hope for improvement of hand function and appearance. So basically, um, any surgery in a rheumatoid hand can improve his function to some extent, and it may improve his appearance of that particular hand. So it's not definitely going to make it completely normal. Of course, we all of us know that. So this is a clinical picture. You can see that a rheumatoid hand bilateral, there are deformed MP joints, there's ulnar drifting of the fingers, there's a deformity in the thumb, and there is involvement of the wrist, which can extend to elbow, shoulder, and something like this. So you can see this X-ray. So this is a typical X-ray, which when we see a bilateral rheumatoid case, and there's destruction of the wrist joint, MP joints. There's some drift towards the ulnar side of the fingers, and a Z deformity in the thumb. So that's how typically a rheumatoid hand X-ray looks like. And I put this X-ray because in this X-ray, if we see the wrist joint is completely fired. There's almost autofused wrist joint. It looks like a skeletally just nearing maturity or just mature skeleton, but the MP joints are relatively not involved to that matter. So this is a typical case of a juvenile rheumatoid arthritis, in which we usually see we don't see rather involvement of the metacarpophalangeal joints, which otherwise is very common in adults when we see rheumatoid arthritis. So MP joints are involved, and also all of us know that DIP joints usually are very less commonly involved in rheumatoid. They are involved in osteoarthritis. So it's the commonest inflammatory disease affecting the hand. As I told earlier, it's a systemic disease, an inflammatory disease. So it's a progressive disease if it is not treated properly medically in the initial stages. So it can go on progression depending on patient to patient, and it involves synovial, tendon sheaths, ligaments, joints are involved later on, articular cartilage is involved, and later on, once the joint is destroyed or deformed, we can say, then there are deformities, and then deformities, then they can lead to compression of the adjacent structures, which troublesome usually are the tendons and the nerves, and then they can lead to some maybe a carpal tunnel syndrome or a cubital tunnel syndrome, or rupture of the tendons or compression of the structures, and of course major deformities by the end stage. In early stage, most of the time when we see, or all the rheumatologists must be seeing, in early stage, they present as synovitis. They can just present as a trigger finger, a decurrence, or a intersection syndrome, or any kind of a tenosynovitis, because the disease starts in the synovium and tendon sheath initially, and then it progresses, and then the destruction of the joints and deformities occur later on. So in early stage, they present as synovitis, which is very well treated medically, and the deformities which we see later on, we can classify them into fingers, the deformities which occur in the fingers, in the thumb, wrist, and there is rupture of the tendons. So usually the sequence of joint involvement, apart from the JRA, juvenile, which I told earlier, is usually in adults, which we see MCP joints are involved first, then wrist joint, and then interphalangeal joints. That is usually the sequence. However, it can be completely random. You never know how it can present or how it can involve various different joints in our body. Ulnar deviation and volar subluxation of the finger, that is one of the commonest deformities. So quickly, I'll go with the deformities which we see in the fingers. That is intrinsic plus deformity, when there's contracture of the intrinsics and there's an intrinsic plus kind of a deformity, a swan neck deformity, a boutonniere's deformity, and ulnar drift of the finger. So these are the commonest deformities, and most of the times we can see a combination in one single hand or in both the hands. So a couple of fingers will have and swan neck deformity, and the others have boutonniere's deformity, and they may have combination with ulnar drift of the fingers, and plus even intrinsic plus deformity. Like in this particular figure, you can see this is a Von Jackson lesions. Actually, there's this rupture of the extensors of these three fingers. That is what it is. It is maybe leading to a finger drop, or there's an intrinsic plus kind of contraction. So these particular two fingers, ring and little finger, are having a swan neck deformity. Even the index finger. So that's how they present. This is a typical boutonniere's deformity. There's a flexion at the proximal interphalangeal joint and hyperextension at the DIP. And this is ulnar drift of the fingers. And you can see if these thumbs are usually into hyperextension, one of the commonest reasons of these thumbs to be in hyperextension is rupture of the flexor pollicis longus tendon. So which is very common because of the bony spurs somewhere in the wrist, scaphoid. So this rupture in these thumbs are most of the times in hyperextension. And when we carefully examine these, and there are rupture of tendons. Sometimes they are the the hands are so deformed, they sometimes they are in a lot of pain, that they even don't realize what actually what how many tendons are ruptured. Or and when you carefully examine, then you realize that yeah, his FPL is not working or his extensors are not working. Or sometimes they will present or given history that there was a snap with while doing some routine work, and then the finger is not going up, or the thumb is not able to flex after that snap. So rupture of tendons is one which bothers them a lot, because the finger becomes kind of dysfunctional. So Von Jackson syndrome is one, that is rupture of the extensors of the ring and little finger, which is very common. I'll go to a couple of cases later on. I'll show those. Then there's a Manifeld syndrome, which is a rupture of the uh, FPL tendon. So this again, I told you, like the extensors come from the dorsum of the forearm and they go to the little and ring finger, and there's always this DRUJ is involved in advanced cases. And once this DRUJ gets unstable and it dislocates dorsally, and there's always a bony spike there. And because of the arthritis, that those spikes, and typically what we see in rheumatoid arthritis is there are sharp bony spikes of the ulnar styloid especially, and they lead to that attrition rupture of the tendons. And these two fingers are very commonly we've seen getting those attrition ruptures, and inability to extend the finger. So that is a classical this von Jackson lesion. And similarly, like I told you earlier, the thumb is again the FPL comes in this direction, and you can see this hyperextension of the thumb. That is probably because of the rupture of the flexor pollicis longus tendon, which gets ruptured by the sharp this scaphoid tuberosity osteophyte or gets sharp. So that is about the tendon rupture. So deformities in the wrist joint. So wrist joint again, it gets involved. There's something known as a caput ulnae syndrome. That is what I told you earlier, like an end stage destruction of the DRUJ. So DRUJ is involved very commonly, and there's radiocarpal arthritis. So there can be distal radioulnar joint involvement, and there can be a radiocarpal joint involvement. So let's come to the management. I'm not going into the medical management part, because I think that is not the topic of discussion today. So, but primarily the medication, the management is medical. So it's a collaboration between surgeons and rheumatologists is a paramount importance to the successful management of rheumatoid arthritis hand problems. So it's always a combination. So like Dr. Nilesh Patil told earlier, that we always have this very good combination of seeing patients together, referring patients to each other to get control. Sometimes I am the person who sees the patient first, maybe an orthopedic surgeon, but patient can be in acute pain, he can be in a stage of stenoitis, he can be in a florid kind of an phase. So he needs a proper medical treatment at that particular point of time, and that has to be done by a rheumatologist properly. So it's better to timely refer these patients to rheumatologists for better medical management, and you will surprisingly see a fantastic outcome after this. And they usually have a good function. They look deformed, they look quite mangled kind of hands, but if their pain is gone, you will realize that they do every routine work, they are used to it, and they are doing everything. If we compare these to nerve injuries, maybe an ulnar nerve palsy, the ulnar nerve palsy patient will be more disabled because his fine movements won't be working, his intrinsics won't be working. But if you see a rheumatoid hand patient who is not in pain, they are they are doing pretty good work. They are not disabled to that extent. So the point I'm trying to make is that it's very important to work in collaboration with the rheumatologist. And of course, I would like to add a physiotherapist there, because their job is also very important. Once the synovitis stage settles, the pain goes. If we do proper exercises, splinting, and other things, they do pretty good without surgery. Of course, there are some splints which do help. There is ulnar drift of the fingers, which can be help. Which can There are many splints available in the market. This oval 8-finger splint is very good. It can be used in many conditions, like if they have mallet finger, it can be used. If they have a swan neck deformity, it can be used for that. Also, a putinear deformity can be used. A crooked finger, or even in trigger finger, it helps. So there are a variety of splints there are available. So I think every patient needs a tailor-made treatment for that particular patient. What is problem in that? he may not be having problem with the deformities or ulnar drift of the fingers. He may have problem with some other problem. So I think careful examination again is very, very important. Examining all the muscles individually, all the extensors, tendons, flexor tendons, see where the pain is, see where the patient is having, what problem he is having, because you cannot correct that whole thing. You cannot make it normal, that hand, but you have to see why patient is there, and why, how can we make him better? Maybe with splints, with some injections, with physiotherapy, with of course medical therapy. So surgery, there are various surgeries which can be safely offered, no, which can help. Some very basic as trigger finger releases or decurvane release, carpal tunnel release, or cubital tunnel release. Then I think, to my personal experience, also wrist fusion and IP joint and DIP fusions do very, very good if the patient has a painful arthritis of that particular joint, or DRUJ. If we fuse, I think, to my personal experience, fusion works very well in these, rather than replacement. However, in Western world, people are doing more of replacements, but in our country, we have seen fusion does a very good job, I think. Tendon repairs, reconstructions, and tendon transfers also helps if there are uh, tendon ruptures, and contracture releases. Sometimes if they develop contracture in advanced stages, they also help. So for in this slide, if I see, I think wrist fusion, DRUJ fusion, and tendon reconstructions, these are the surgeries which really benefit the patient, and they can help. I'll go to some cases. We'll discuss some particular cases. This is a 58-year-old female, known case of rheumatoid arthritis. She had an ulnar pain. After carefully examining her, she did the ulnar sided pain was there, and there was a very bad crepitus on the allotment of the radius and ulna. That the allotment was test piano key sign, you call it. So that was giving her pain. Apart from everything else was okay. So that we could. That's this caput ulnaris syndrome I told earlier, that it's significant involvement of DRUG. So in this particular patient, we did a Suve-Kapanji procedure, which is a proximal pseudoarthrosis and then a fusion of the distal radio-ulnar joint. At 6 months, it was pretty good. You can see other joints looks fairly normal. In this particular case, she was just her DRUG was very badly involved and giving her pain. So I think at this this was the function at 6 months. So she was able to do this pronation and supination. That was before this thing. Before she was not able to just do pronation and supination, and you can see very well she has a good palmar flexion and ulnar this thing dorsiflexion and palmar flexion, and most importantly, very good rotational movement was there. So that was bothering her. So maybe a small surgery. It's not a very big surgery. Can be done under a block. So that can give relief to some patients. So this is another patient, is a 36-year-old female. Uh, she had she had presented with loss of finger extension of little and ring finger. So like Von Jackson lesion, which I told you earlier, you can see in this right side. In this right side, you can see these two fingers are in the attitude of more flexion than if compared to left side. So when you carefully examine, when you try to extend the little finger and the ring finger, there is extension, loss of extension is these two particular fingers. And also if you see, this thumb is in flexion and this thumb is in extension. So probably there is an FPL rupture also, maybe somewhere at the level of the wrist. We can do an ultrasound and see where the level of the rupture is, or if you are clinically sure that the rupture is at the level of the ulnar styloid, or the FPL is ruptured at the maybe a scaphoid tuberosity. So that you can I think go ahead and treat it surgically in that way. So this is the X-ray, and you can see the right side, this DRUJ is completely you can see this dislocated because of the degenerative changes. And that probably, if we see a true lateral view, you can recognize that there is a dorsal subluxation of that radial styloid, of that ulnar styloid. So that is how it causes attrition to these two little extensors of little finger and ring finger, and then subsequently one find it there's a rupture of that. So in this particular case, we explored this. This is the dorsal incision over that, and you can see these two the tendons are gone. So this is there, and once you debride it properly, to see the end of these two tendons, and then you see the actual defect. So it's you cannot repair this, of course. Whenever there is an attrition rupture, it can't be repaired. You have to reconstruct it. So because the actual defect is more. So usually a palmarus longus graft is the commonest graft which is available, which can be taken from the palmar side, and with small stab incisions, minimally invasive way, you can just harvest this graft, and you have to suture it really nicely. There's a weaving technique that is known as a pulver tuff weaving technique. So that particular technique is a robust, very good techniques, and a proper positioning of the hand while doing that tensioning of that tendon is very important, because you don't want it to become over tight so that the patient loses flexion, or it should not be loose so that there is a lag in extension again. So that position has to be balanced. That is the important thing in that. So that was repaired with the palm reconstructed. So this is another patient, is a 38-year-old female. Again, same kind of a thing. There is a rupture of the tendon, extensor tendon, and on exploration you can see how big gap there is. And again, in this particular patient, we had to do this is minimally this stab incision. We take out the palmaris longus, you weave it with the proximal end, you suture it with the distal end, and then you can reconstruct those tendons. And most important thing is, when we are doing it, you have to resect the ulnar styloid, and you have to just do it as a Darras procedure. You can do, or you can just see visibly what offending structure is there which is causing this rupture, and you just shave off that bony spike or remove that ulnar head. If it is bothering too much, the whole distal ulna can be resected in such cases, so that there are no further problems with the tendons. And this is, in this particular case, this was repaired, reconstructed with a palmaris longus graft. So resection of bony spikes is also a very important part of this particular surgery. Then I told earlier, Manner-Felt syndrome is there is an hyperextension of the thumb, and sometimes index finger. It looks like an AN palsy, maybe anterior interosseous nerve, but you can see carefully, and this is the scaphoid tuberosity, which is causing the rupture of the FPL tendon. So that is another thing which can be treated with a tendon transfer. This is a 28-year-old female. She was on treatment of rheumatoid arthritis, but continuous wrist pain in both. She was having symptoms on the right side more. She's 28 years old, and left side you can see relatively the joint is not very bad. However, there are some osteolytic lesions, but this looks okay. The right side is not. The right side is very bad. You can see the cartilage is completely gone. So she was having a lot of pain. There is no movement in the wrist. Hardly any jog of movement is there, and that is painful. So that is a very bad situation in a young female. So in this particular case, we did her total wrist fusion. So just resect out all the cartilage, remove the ulnar head, and then you can see that there's a dorsally this plate is applied and the wrist is fused. This is 1 year of her follow up. You can see there is some consolidation happening here. This is trying to incorporate completely and fuse. And this was recently she had come for follow up, and this is 2020 X-ray. In June she had come, and you can see this is completely fused. So this, you can see there's a strong bony fusion. There is a good position in 30-degree dorsiflexion so that they get that grip strength. And she was completely free from pain, which she had earlier. And luckily in this case, she had only wrist involvement. So as I told earlier that there is a lot of the varied presentation. You can see some people have presentation in fingers, and only fingers, and this particular girl had wrist involvement only. And this is the clinical picture. He had a good grip strength, and this is the this is a finger movement. She's able to do pronation, supination. Her grip is strong. She's practically doing everything. but her wrist is fused. So a wrist fusion, it may be sometime, it seems to be it's a morbid surgery or there's a functional disability later on. But I don't think it is much of a problem, because see, when we see such patients which need this surgery, they are they are usually, they don't have wrist movement anyway, and whatever wrist movement is there, that is painful. So they anyway don't have any use. They have nothing to lose. That's already gone. So you just make a sound fusion, remove the damaged cartilage and fuse it, and then they are happy. These patients are happy. Sometimes we do this tougher procedure. That is, whenever there's this particular lady, this is a bilateral involvement, and if an alignment of these fingers needs to be improved, I must say this is more of a cosmetic procedure than any functional procedure. The volar plate is released on the volar on the volar side, so you get a functionally little bit better hand and cosmetics and function. So this particular patient, again a 42-year-old male patient, he has his distal DIP joints were involved more. Again, a surgery, any particular finger which is giving her pain. Sometimes a DIP arthritis gives a lot of pain, especially whenever your finger is touching any object or somebody is just touching it or sitting on it or something. It's very painful, and there's deformity, varus valgus deformity. So in this particular case, we had done a fusion of the DIP. As I mentioned earlier, that fusions are very good options in such patients. So this particular, for example, this ring finger was fused with a small Herbert screw, and this is done under local anesthesia, maybe in half an hour job. And this is, intraoperatively we check all the movements, because this has to be fused in certain degrees of flexion, maybe 20-degree flexion, so that whenever a patient makes a grip, there is a good cascade of fingers and there's a good strength, because you can't keep it in full extension. And that is the this is the x-ray. This is showing good fusion here. This is at 2 months. I'll just talk a little bit, couple of slides on elbow, and I think that will be end of it. So because elbow joint is also very commonly involved, this was a monoarticular rheumatoid. She had a fixed flexion deformity from 30 to 90 degrees. So very disabled, cannot eat with the right hand. Family was bothered. She's young, not very old, 65 years old. So, and a painful arc. She has just 30 to 90-degree motion, and that is painful. So you have to do something for that. When you see X-ray like this, and you can give a local steroid injection maybe into the elbow joint, that can give her some relief, but she's going to come back with the symptoms, because that is not the permanent solution. So whenever we see, we can offer we have done a total elbow replacement in this patient. So this is an intraoperative picture. This is what you see. This is the radio. This is completely gone. This distal humerus is, there are big cartilage defects which are there. So it's obviously going to give pain. There is stiffness. So this particular lady was operated with an elbow replacement, and she did pretty well. This is the video, and this is on day 3. You can see the dressings are still on, and she's going almost till 110, 120 degree or more. That is on day 3, and she started eating with her right hand. So I mean, that is also sometimes we have to consider. Although the longevity of this process is maybe 15 to 20 years max, she'll come back after 20 years with loosening maybe, or with some symptoms, and then we have to do something for that. But definitely better to have a painless range of motion rather than a painful stiff elbow. So that particular patient, I'll end my presentation with this. Thank you very much.
Thank you, Dr. Warid, for sharing these valuable inputs. I am sure we all have learned a lot today. Yes, so I should start referring more patients to you. Those are really
I think maybe half of the patients in these are referred by you probably.
Yes.
Because that, yeah.
Really, even I was unaware of these many outcomes.
Yeah. So I think the only point I want to make is there are certain surgeries which do help.
Yes.
But I think 90 to 95% of patients should not be touched.
Yes, yes.
Sometimes they are badly deformed, but you can correct them. X-ray will look good, but functionally they will not uh, be good.
Yes, yes. Tell us something more about elbow replacement surgeries, because we see lots of patients with severely deformed elbows.
Right.
And so sometimes those patients, once they do the elbow replacement, they
Yes.
come with the recurrence. So
Yeah.
what do you think, and what is your suggestion for elbow replacement
I
surgery?
think I think very limited, we have done it here, maybe 4 or 5 replacements till now, not many, because the patient selection has to be very carefully selected,
Yes.
because the patient should be happy. One is, it's a major procedure. It involves a lot of cost also, that has to be considered, and the age, because it the problem with the elbow replacement is why it is not so famous or done routinely in our country, is because of the longevity of the prosthesis.
Yes.
It does not last more than 10 to 15 years, or sometimes 20 years, which is, you have to tell patients not to lift heavy, this thing more than 8 to 10 kgs is not allowed. He
Yes.
can do all the routine activities, but then they have to be very careful not to lift heavy things. So that is very important, because most of the time what they do is, when they realize, they get very good movement,
Yes.
initial 1 month to 1 year, they keep on improving. They keep on
Yes.
improving. They are very happy and they are pain free. So then they start doing everything. फिर वो सब उठा लेते हैं, कुछ काम भी कर लेते हैं, and then we realize that it is getting loosened or something is happening, because it's a upper limb joint. The gravity is having a role,
Yes.
and unlike lower limb, it's a weight bearing joint. They don't have these kind of problems.
Yes.
So another thing, and why sometimes they may have pain, even after doing a very good surgery. You can see a good X-ray, good movement, but pain that can be contributed by this. If the synovectomy has to be done properly, once we do a replacement, it's not just ending cutting the bones. It's a synovial disease. We have to remove all the abnormal, the pathology in the synovium. Otherwise, that can cause pain. You may have good movement, everything looks fine, but pain is still there. So that also is important. So I think selection of that patient is very important,
Yes.
preferably above 70, 75.
Okay.
In Western world, they are doing it left, right, and center, because they can do revision at 5 years, 10 years. Cost is not a problem. Patients are also more or less, following the instructions properly. So here it is difficult.
Yeah.
So,
Good evening.
yes, good evening.
Dr. Altaf, very nice presentation,
Yes.
and we learned a lot. I'm sure your surgeries have expanded our understanding of hand surgeries. I would
Yes.
like to know your experience about psoriatic arthritis hand, because usually they have more severe form of like hand deformities, telescoping and shortening.
Yeah.
Are they those correctable? And I mean, how you think they
I
come
think, yeah, I think
to rheumatoid?
I think the difference in that is that they are more destroying the bone more. There
Yes.
are like punched out lesions
Right. Right.
in the bones, subchondral areas, and more of articular destruction. But the principle of surgeries would remain probably the same
The same.
in
Okay.
those
Okay.
also. What we do in
There are
rheumatoid arthritis, because
proliferative changes also. A lot of
correct,
proliferation.
yes, there is more proliferation, and I think more extensive damage than rheumatoid arthritis.
Yes.
But principles, as I told every time, that there is a limited surgical role, which may help tendon ruptures, or nerve decompressions, or joint fusions. So in psoriasis we see a lot of DIP joint involvement also.
Right.
So
Right.
we have done a lot of DIP joint fusions in psoriatic patients. So
Okay.
they help, but otherwise primarily I think medical management.
Okay.
Sir, I have a
Thank you.
question.
Yeah.
How do we monitor these post-surgical patients? You do USG or you do MRI? How do you monitor exactly?
I think most of the time both are not done. Pre-operatively, we can do a USG if we are seeing some tendon rupture. If we are suspecting, or clinically we are not showing where the rupture is, which is rarely there. Most of the times
Yeah.
we are sure where the rupture is, and we don't even do ultrasound. But post-operatively, it's all about, you can see it clinically. For example, if you have done an extensive tendon reconstruction here, so she has to be immobilized for a long time. So she'll
Yeah.
be in a splint for maybe 6 weeks in dorsiflexion till the whole thing heals on this side, And then there's a particular protocol of starting
Okay.
finger flexion with the splint on with some rubber bands, and then gradually starting wrist flexion. It takes 2 months at least for them to go start slowly going back to normal, maybe 3 months. So monitoring is clinically. Very rarely a repeat ultrasound or something is done if there's a re-rupture or something like that to document that or some. But otherwise, following up is clinically. For fusions, it is X-rays.
Okay.
We see serial X-rays every month, every 6 weeks, and see how bone is, trabecular formation is there across the joint, or that's how it is followed up. Plus extensive this medical therapy also. Sometimes it should not flare up the this thing the synovial the initial stage.
And
So
how
that
are the outcomes with
usually
these tendon transfer surgeries?
I think they are good. See, overall their hands are very bad,
Yeah.
and maybe they will sometimes I can say this FPL is a very important tendon. If they lose this flexion, they have a lot of disability. Then
Yes.
if we do a tendon transfer for FPL, they are very happy. Then they are able to do this. Similarly, extensor when there's a drop, finger drop, sometimes all four drop. So they are happy. I think, and nerve decompressions. Those patients are really happy.
Okay. Dr. Warid, can you just tell us how can we identify impending tendon rupture?
Right. Mhm.
So, for the optimum time for referral, for best outcomes.
Yeah, absolutely. That's a very good question and a difficult question also, I think. So I think, I think what everybody needs to be aware of which tendons are usually ruptured, because there's a very particular sequence and it always follows that pattern, which I have seen, especially with the tendon ruptures. Because the tendon ruptures is always because of the bony spikes, osteophytes, or subluxation of the joints, which is continuously irritating. So commonest is the distal ulna. The distal ulna DRUJ gets unstable. There is arthritis, and it goes up, and then it starts hitting the extensor tendons on the dorsum of the wrist. So that is we always have to keep on checking the extension of especially these two fingers. Okay, so and similar is a case of FPL. So now I think if there's a big bony spike, if there's a big, how we can prevent that is if there's a big bony spike here, but the tendon is working fine, we know it is fine, but there is a problem. No, if there's a big deformity there, it can rupture. So I think immobilizing or splinting them in that phase will definitely help, because when we keep it in supination, when we keep our hand in supination like this goes inside. That's a functional position. So maybe splinting them in supination will definitely help to prevent rupture of these extensor tendons for 6 weeks, or for 1 month. If they are splinted, then that will prevent the extensor tendon rupture definitely. And similarly, I think, I don't know, I mean, regular exercises, that may help keeping nutrition in the tendons. That glucosamine or all those things sometimes we give. I think that is the only way to prevent, but usually it is inevitable most of the times, because the symptoms, patient will never have a symptom. He will not have pain, or he will not tell us that this is weak or something. One fine day it just snaps and there's a finger drop.
And so, what are your opinion about these CTS surgeries, means tendon release surgeries for CTS?
See, carpal tunnel. No, I think that is one of the best surgery in hand surgery. I must say, most rewarding surgery in hand surgery is a carpal tunnel release.
Yes.
Because last week only we had one webinar and we were discussing a lot about carpal tunnel releases and this thing. These patients are very disabled. Those who have carpal tunnel syndrome, you are seeing a lot of carpal tunnel syndromes, I know. They have that lot of night pains, nocturnal acroparesthesia, not sleeping at night, and later on if there is a chronic case, this thin arm wasting, and
Yes.
this opponent gets very weak, and abduction of the thumb gets weak.
Yes.
That really disables them. I think whatever we have done, or whoever is doing these carpal tunnel releases, the response, or the patients have a dramatic relief of symptoms, I must say.
Yes.
One is from the pain point of view, they are very, very happy. I think next day the patient will say that I was able to sleep properly this night. And also, if they have a motor deficit because of chronic compression, that also recovers over a period of time. Surprisingly, sometimes we see a wasting of thumb, and we realize कि ये तो अभी पता नहीं वापस होगा कि नहीं, but they also develop that. So my personal experience is I think that is the only surgery in which I am also happy. That patient is going to be happy. They always are happy after this carpal tunnel release.
So Ajit sir, do you have any question for Dr. Altaf?
Okay. So Dr. Warid, one more thing about this carpal tunnel syndrome. Sometimes, can you clinically make out whether it is at the wrist, the median nerve compression, or it is higher up? So how will you how do you proceed? Whether it's
Okay. Yeah. I think again a very good question. Most of the times when we see a carpal tunnel syndrome, patient will always complain of pain, ऊपर भी होता है थोड़ा, ये भी होता है. तो it is very difficult to come to a conclusion कि ये carpal tunnel ही है कि कुछ और है, और कहीं compression है. So so the neck pain is one of the commonest sites. So I always tell them how much pain is in the neck and how much pain is in the hand. What about your night pain? So most of the times they have compression in the neck. What we call it as a double crush syndrome. So there's a compression in the neck, and there's a compression in the median nerve as well. So that has to be ruled out. Very, very important, because if we do a release in a patient in which the compression in the neck is probably more, she will not be that happy. She may have relief of symptoms still, because there are many studies which say even in double crush syndrome, if you release at one particular point, they will have overall relief of the pain because the nerve gets decompressed. But still, they will not be that much happy as you would want them to be, because their neck pain will not go. And that is one thing. And very rarely there is an ulnar median nerve entrapment in the forearm, or in the elbow, around the elbow. The ulnar nerve is very commonly involved in a cubital tunnel, but a median nerve, I think very rarely it gets entrapped somewhere in the lower end of the humerus around the elbow joint. But clinically, there are certain tests still which we should always do to see whether there is a high median nerve or a low median nerve kind of a palsy. But the problem is that when we are treating these carpal tunnel patients, when we see most of them, they are in the early phases. They don't have that motor deficit. They just have sensory symptoms, painful symptoms. So they get good relief with the surgery. But if we have to differentiate whether it is lower or upper, we have to check power of the muscles. So in early stages, the power is not yet gone. The muscles are still working. But still we have to check. We can check the long flexors, long deep flexors, that is the FDP of the individual finger, because FDP is supplied by the median nerve higher up. And if that is weak, that means there is a compression maybe proximally as well. Otherwise, only the small intrinsic muscles of the hand are involved in the lower nerve palsy. So I think clinical examination is very, very important. In all these things, I think we cannot rely on investigations. Clinical examination is best. Of course, we can do EMG and CV, which can tell us compression is in the here. But I still rely personally on clinical examination. And most of the times, if patient is convinced, patient वहीं से आके बोलते हैं आपको अब टेस्ट करना है कि आप अगर श्योर हो तो टेस्ट क्यों करना है. So I tell them, if you are okay, we will not do EMG and CV, because we are sure that it is this thing. Even KHS sir used to tell me when he used to refer patients that if you are sure carpal tunnel है तो क्यों करना है EMG and CV, release करो, So I remember that time always that clinical examination is best to diagnose all these tendon ruptures or carpal tunnel syndrome. Yeah.
Yes.
I think we are on time.
Yeah. Okay. Should we end the meeting or?
We should.
Yeah.
Yes, Dr. Abhishek, do you have
Any
No,
other?
no. Very nice
any
presentation.
question
Thank
for
you.
So,
Dr.
in
Gayatri?
fact,
Thank you
Dr.
so much.
Warid, if he has any suggestions or comments for rheumatologists, maybe
Yes.
like
If you have any question for us, you
or
can
any
go ahead and
question
ask.
for rheumatologists.
Yeah,
Yes.
I can ask you question. Yeah. So I think the current trend, because most of the orthopedic surgeons start the rheumatology treatment on their own, honestly speaking.
Yes.
I don't know how timely they do refer the patients to rheumatologists, but I think if you can tell us quickly, Ajit sir, that now I think I was discussing with Dr. Nilesh also that now the trend is to start aggressively initially and then go slow, not go slow and then increase. So what is the current consensus regarding the medical treatment?
Currently, we have a lot of evidence-based guidelines, and that should be followed. In fact, we have a lot of options. Our treatment armamentarium is increased and is increasing. There are many new drugs as well coming out, and which are very safe, effective, etc. So timing is of essence, and in fact, most patients gain benefit if they are initiated treatment early. Okay, so
Right.
so it is very important that we follow certain recommendations. Usually, if conventional medicines are tried first, then we go for advanced therapies, etc., etc. And along with it, if patient has already presented late, uh, if we involve orthopedicians or other multidisciplinary healthcare providers when inflammation has reduced to take care of other aspects, that will give very good outcomes for the patients.
Absolutely. So I think it has to be a team approach. The patient will definitely be much more benefited than if individually one person is treating them for a longer period of time.
Even the people are getting more aware these days. They are so seek for the
Yeah, yeah.
specialists. Yeah.
So rheumatology is one branch which has come up very big time in treating such diseases.
Yes.
Okay, I think we'll
Yes.
call
Yes.
it for the day now. Yeah.
Yeah.
Yeah, it was great connecting with everyone.
Yeah.
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 Yes. Thank you, Dr. Warid.
Thank you everybody.
Yes.
Thank you
Thank you,
for
Yeah.
Dr.
Thank you.
Gayatri,
Thank you.
Ajit sir, yes, Abhishek for the
Thank you,
enlightening
Dr. Ajit.
discussion.
Yeah. Thank you. Yeah.
Thank you, Abhishek, for joining us.
Yes.
Yes. Thank you,
Thank
sir.
you, Gayatri. Yes.
Thank you for
Thank you,
giving
sir.
chance.
Yeah.
Maybe next Wednesday, Abhishek is going to
Yes.
speak
Yeah.
on some
Yes.
topic. Okay.
Okay.
So thank you all.
Thank you.
Yes, sir.
Bye.
Yes, sir.
Yes. Thank you. Yeah.